Look after yourself from within, and your beauty will shine through on your skin. Left double quotation mark. Shannon, a Sheikh model. Low 1. Explain why cosmetologists need to understand skin disorders and diseases. Why study skin disorders and diseases? The skin is the body's largest organ. It offers protection from harmful organisms. It is the first defense against environmental assaults, and helps regulate body temperature. Skin disorders and infections can either be a minimal medical concern or present life-threatening situations. By studying skin irregularities, you'll be able to discover signs of common skin disorders and diseases that other people do not see, especially on the scalp, ears, and back of the neck. You can also recognize common conditions that can be treated within the scope of your license, know when to recommend specific skincare preparations, and when to refer clients to a dermatologist, who can diagnose and medically manage the condition. When in doubt, refer to a healthcare provider. You may also be passionate about doing skincare therapies in addition to hair services. Performing aesthetic services can alleviate your own symptoms caused by the daily physical exertion, and the aches and pains that follow, associated with doing hair. You don't need to choose between hair and skincare services. Some cosmetologists split their workday between skin and hair. Others dedicate specific days to skincare therapies. Cosmetologists need a thorough understanding of skin disorders and diseases because providing skincare services requires an understanding of the skin's structure and common skin problems. Recommending appropriate skincare preparations to clients requires thorough knowledge of the skin and potential disorders. Recognizing when salon services can be safely performed, and when the skin condition merits a healthcare provider referral, is crucial to managing a safe practice. Check-in 1. Why is it important for cosmetologists to study skin diseases and disorders? Low 2. Identify and describe common skin lesions, differentiating between primary and secondary lesions. Common skin disorders and diseases. You cannot serve a client with an inflamed skin disorder, infectious or not, without a physician's note permitting the client to receive services. Sensitively suggest that proper measures be taken to prevent more serious consequences. One of the most visible signs of a skin issue is inflammation that may present as swelling and redness, often with no known cause. Inflammation can be short-term, such as a sunburn. Long-term inflammation is concerning, as it can cause permanent tissue damage. When clients have long-term skin inflammation, refer them to a dermatologist to determine the cause and discuss possible treatments. Here's a tip. Declining a service does not have to be uncomfortable. Using sensitivity and concern, and without diagnosing or speculating about the disorder, suggest that the client seek medical advice. For example, you could say, "I'm concerned about this area on your forehead. Before I do any treatment on it, I need you to see your healthcare provider for an evaluation. Would you be interested in a relaxing nail service today instead to avoid this area?" Clients will appreciate your concern and know that you have their best interests at heart. Suggesting an alternative service that is safe is a great option for disorders that are not contagious. Skin lesions. Lesions are structural changes in the tissues caused by damage or injury. Any mark, wound, or irregularity is described as a lesion. The 3 types of lesions are primary, secondary, and tertiary. Some tertiary lesions may be referred to as vascular lesions because they involve the circulatory system, including the blood. We will focus on primary and secondary lesions in this section. While all skin is essentially the same, certain conditions on darker skin may not be as noticeable. For example, lesions that are typically red or pink may appear gray or purple on pigmented skin. Always refer clients to a dermatologist if you encounter a lesion you do not recognize. Primary lesions. Primary lesions are lesions in the initial stages of development or change. The lesions are a different color than the surrounding skin and can be flattened or raised above the skin's surface, formed by fluid in a cavity. They are often differentiated by size and layers of skin affected. Refer to Table 4.1 for a description of primary lesions and examples of each. Table 4.1 Primary lesions primarily see on. Bula. Plus bonus to access more. Graphics. Scan or visit. Bonus Milady Cos B4. Description examples. Large blister containing a watery fluid, similar to a vesicle, requires medical referral. Contact dermatitis. Large second-degree burns. Bulbous impetigo. Pemphigus. Cyst and tubercle. Closed. Irregularly developed sac that contains pus, semi-fluid, or morbid matter, above or below the skin. A cyst can be drained of fluid but a tubercle cannot. The latter requires medical referral. Macule. Flat spot or discoloration on the skin. Cyst. Severe acne. Tubercle. Lipoma. Erythema nodosum. Freckle or age spot. Nodule. Solid bump larger than 0.4 inch. 1 centimeter that is easily felt. Requires medical referral. Swollen lymph nodes. Rheumatoid nodules. Papule. Small skin elevation that contains no fluid but may develop pus. Acne. Warts. Elevated nevi pustule. Raised. Inflamed. Papule with a white or yellow center containing pus in the top of the lesion. Acne. Impetigo. Folliculitis 70. Primary lesion tumor. Description. Any type of irregular mass varying in size, shape, and color, not always cancer, requires medical referral. Examples: cancer. Vesicle. Small blister or sac containing clear fluid, lying within or just beneath the epidermis, requires medical referral if cause is unknown or untreatable with over-the-counter products. Wheal. Itchy. Swollen lesion caused by a blow, scratch, insect bite, urticaria skin allergy, or nettle sting. Typically resolves on its own, but refer to physician if condition lasts more than 3 days. Poison ivy. Poison oak hives. Mosquito bite. Secondary lesions. Secondary skin lesions are characterized by an accumulation of material on the skin surface, such as a crust or scab, or by depressions in the skin surface, such as an ulcer. These may require a medical referral. Refer to Table 4.2 for a description of secondary lesions and examples of each. Table 4.2 Secondary lesions. Secondary lesion. Crust description. Dead cells that form over a wound or blemish while healing. Accumulation of sebum and pus, sometimes mixed with epidermal cells. Examples: scab, sore. Excoriation. Skin sore or abrasion produced by scratching or scraping. Nail cuticle damage from nail biting. Table 4.2 Secondary lesions. Secondary lesion. Fissure description. Examples: crack in the skin that penetrates the dermis. Severely cracked and/or chapped hands, lips, or feet. Keloid. Thick scar resulting from excessive growth of fibrous tissue. Keloids will form along any scar for people susceptible to them. Thick, raised scar scale. Thin, dry, or oily plate of epidermal flakes. Excessive dandruff. Psoriasis. Scar or cicatrix. Slightly raised or depressed skin area formed as a result of the healing process related to an injury or lesion. Ulcer. Open skin lesion or mucous membrane of the body, accompanied by loss of skin depth and possibly weeping of fluids or pus. Requires medical referral, particularly in clients with underlying medical conditions such as diabetes. Postoperative repair. Chicken pox. Herpes. Check-in. 2. What is a primary skin lesion? List 3 types. 3. What is a secondary skin lesion? List 3 types. Low 3. List and describe common sebaceous and sudoriferous gland disorders. Sebaceous and sudoriferous gland disorders. There are several common disorders of the sebaceous oil and sudoriferous sweat glands that cosmetologists should understand and identify. Disorders of both glands can lead to painful skin conditions and possibly permanent scarring. Sebaceous glands. Sebaceous glands are microscopic glands in the skin that secrete a fatty or oily substance called sebum to lubricate and waterproof the skin. Too much sebum can contribute to several disorders, including acne and cysts. Comedones. A comedo is a non-inflamed buildup of cells, sebum, and other debris inside follicles. An open comedo, also known as a blackhead, is a hair follicle filled with keratin and sebum. Figure 4.1ab. When the comedo's sebum is exposed to the environment oxygen, it oxidizes and turns black. Comedones appear most frequently on the face, especially in the T-zone, the center of the face. A closed comedo, also known as a whitehead, is a bump just under the skin's surface that appears when the follicle is not exposed to the environment. The sebum remains a white or cream color. State laws and regulations on the removal of comedones and extractions vary. Check your state's guidelines. B. Figure 4.1 A and B comedones. Milady Figure 4.2 Milia. Milia are tiny benign harmless, keratin-filled cysts that appear just under the epidermis and have no visible opening. They develop when skin flakes become trapped in small pockets near the skin's surface. Milia are firm, perfectly round whitish masses usually the size of a small sesame seed. They are commonly associated with newborn babies but can appear at any age. They are usually found around the eyes, cheeks, and forehead. Figure 4.2. In many states, only physicians can remove milia. Removal requires piercing the skin with a sharp instrument called a lancet. Chapter 0. Acne vulgaris. Figure 4.3 A and B acne. Epidermoid cyst. An epidermoid cyst, commonly called a sebaceous cyst, is a large protruding pocket-like lesion filled with keratin. Sebaceous cysts are frequently seen on the scalp and back and may be surgically removed by a dermatologist. B. Acne, also medically known as acne vulgaris or acne simplex, is a skin disorder characterized by chronic inflammation of the sebaceous glands from retained secretions and bacteria known as Propionibacterium acnes. P. acnes. Acne will be discussed in greater detail later in this chapter. Figure 4.3 AB. Seborrheic dermatitis A. Figure 4.4 and B. Seborrheic dermatitis B. Seborrheic dermatitis is a skin condition caused by chronic inflammation of the sebaceous glands and is often characterized by redness, dry or oily scaling, stubborn dandruff, crusting, and/or itchiness. Figure 4.4 AB. The red flaky skin often appears in the eyebrows, beard, scalp, hairline, middle of the forehead, and sides of the nose. It is not contagious. The cause may be changes in skin cell functionality, environmental factors, an immune deficiency, or the colonization of lipophilic yeast. 1. While seborrheic dermatitis is a medical condition, applying non-fatty skincare products designed for sensitive skin can help. Refer moderate to severe cases to a dermatologist. Contact dermatitis is discussed in the last section of this chapter. Rosacea. Rosacea is a chronic condition. Figure 4.5 Rosacea. That appears primarily on the cheeks and nose. It is characterized by flushing, redness, and, in some cases, symptoms can progress to pustular-type breakouts that can be confused with acne. Acneic rosacea includes papules and pustules. The cause of rosacea is unknown, but genetics is one possible theory. Heat and sun exposure, very cold weather, stress, and ingestion of spicy foods, caffeine, and alcohol are factors known to aggravate the condition in some individuals. Rosacea can be treated and kept under control by using medications prescribed by a physician, using skincare products for sensitive skin, and avoiding the aggravating flare factors listed above. Telangiectasia. Telangiectasia is a condition involving visible capillaries, 0.02 to 0.04 inch, 0.5 to 1.0 millimeter in diameter, commonly found on the face, particularly around the nose, cheeks, and chin. Figure 4.6. It can appear due to injury, heredity, rosacea, hormonal changes, or extreme cold or heat exposure. A matting of tiny telangiectasia creates a ruddy complexion called cuparose skin. Telangiectasia is a cosmetic irregularity, not a medical condition. Figure 4.6 Telangiectasia. Sudoriferous, sweat, glands. The sudoriferous, sweat, glands discharge sweat, a transparent colorless acidic fluid that contains some fatty acids and mineral matter. Disorders arise from a variety of causes, including bacteria and nerve damage. Anhidrosis is a deficiency in perspiration or the inability to sweat. It is often a result of damage to autonomic nerves. This condition can be life-threatening and requires medical attention. Bromhidrosis is foul-smelling perspiration, usually noticeable in the armpits or on the feet, generally caused by bacteria. Treatments vary from over-the-counter preparations to Botox injections and the use of lasers on the sweat glands. Severe cases require a medical referral. Hyperhidrosis is excessive sweating caused by heat, genetics, stress, medications, or general body weakness. Hyperhidrosis requires a medical diagnosis and treatment. Miliaria rubra, also known as prickly heat, is an acute inflammatory disorder of the sweat glands characterized by the eruption of small red vesicles accompanied by burning, itching skin. It is caused by excessive heat exposure and usually clears in a short time without treatment. Chapter 0. Activity Disease Flashcards. With 3 classmates, find pictures of skin diseases and disorders. Glue or tape these pictures to flashcards and write the definition on the other side of the card. Quiz each other using the cards. Check-in. 4. Name and describe at least 5 sebaceous gland disorders. 5. Name and describe 4 sudoriferous gland disorders. Low 4. List and describe common skin inflammations and infections. Skin inflammations and infections. Skin inflammation does not necessarily indicate there is a skin infection, but a skin infection can cause skin inflammation. Skin inflammation. Inflammation is a defense mechanism that occurs when something harmful or irritating affects a part of the body. This biological response is intended to remove or eliminate the offending object or organism. While inflammation symptoms can be uncomfortable, they are signs that the body is trying to heal itself. Dermatitis. Dermatitis is a generalized term for any inflammatory skin condition. Various forms include lesions such as eczema, vesicles, or papules. Referral to a medical professional is recommended for appropriate diagnosis. More detailed information is shared in this chapter. Eczema. Eczema is an uncomfortable inflammatory skin disease that is often chronic. It is characterized by moderate to severe inflammation, scaling, and sometimes severe itching. There are several different types of eczema. The most common is atopic eczema, which is a genetic disorder. Eczema is not contagious. Refer all eczema cases to a healthcare provider. Skin infection. Infectious skin diseases can be caused by bacteria, fungi, viruses, or parasites. Most skin infections are highly contagious. Bacteria enter the body through a break in the skin. Viral infections are typically transferred through mucous membranes, saliva, or fluid oozing from a sore. They can be mild enough to respond to over-the-counter medications or severe enough to require immediate medical treatment. Conjunctivitis. Conjunctivitis, also known as pink eye, is an eye infection and may be caused by a bacterium or a virus. Figure 4.8. It can be extremely contagious. Politely reschedule and refer clients with conjunctivitis, or even just obviously irritated eyes, to a healthcare provider immediately. Impetigo. Impetigo is a contagious bacterial skin infection characterized by weeping lesions. Figure 4.9. Staphylococcus bacteria usually cause it. Impetigo typically occurs on the face, especially around the nasal passages, and is most frequently seen in children, although it can manifest at any age. Politely reschedule and refer clients with weeping skin or open facial lesions to a healthcare provider immediately. Herpes simplex 1. Herpes simplex 1 is a recurring viral infection that often presents as a fever, blister, or cold sore, although many people have no symptoms. Figure 410ab. It is characterized by the eruption of a single vesicle or group of vesicles on a red swollen base. The blisters usually appear on the lips, nostrils, or other part of the face, and the sores can last up to 3 weeks. Herpes simplex 2 is caused by the same virus and is designated as type 2 because it occurs below the waist. Herpes simplex is contagious and requires a medical referral. Figure 410a and B. Herpes simplex I. Caution. Check-in. 6. Define skin inflammation. Name 2 skin conditions that cause skin inflammation. 7. What causes skin infections? Name 3 infectious skin diseases. Throw away any products touching infected eyes. Properly clean and disinfect all implements immediately. Figure 4a. Low 5. Identify skin hypertrophies. Skin hypertrophies. A hypertrophy is an irregular growth of the skin. Many hypertrophies are benign, harmless. An understanding of common hypertrophies will help you easily recognize them. A keratoma is an acquired superficial thickened patch of epidermis. A callus is a keratoma caused by repeated pressure or friction on any part of the skin, especially the hands and feet. Corns are a thickening of the skin that form on pressure areas of the foot. A mole is a small spot or blemish on the skin. Moles range in color from pale tan to brown or bluish black. Some moles are small and flat, resembling freckles. Others are raised and darker in color. Large dark hairs often occur in moles. Any change in a mole requires medical attention. A skin tag is a small brown or flesh-colored skin outgrowth. Figure 411. Skin tags occur most frequently on the neck and chest, and can be easily removed by a dermatologist. Figure 411 skin tag. Caution. Do not treat moles or remove hair from moles. Removing a hair from a mole could irritate or cause a structural change to it. Only a physician should remove a hair from a mole. Psoriasis is a skin disease characterized by red patches covered with silver-white scales and is usually found on the scalp, elbows, knees, chest, and lower back. Figure 412AB. Psoriasis is not contagious, but it does require a medical referral. It is treatable but not curable. B. Figure 412A and B. Psoriasis. A verruca, also known as a wart, is a hypertrophy of the papillae and epidermis. Figure 413. It is caused by a virus and is infectious. Verrucas can spread from one location to another, particularly along a scratch in the skin. A dermatologist can remove and reduce the recurrence of warts. Check in 8. List and describe the 5 hypertrophies. Figure 4. Low 6. List and describe common skin pigmentation changes. Pigment disorders. A person's genetic background influences pigmentation disorders. Hyperpigmentation, overproduction of pigment, and hypopigmentation, lack of pigment, are pigmentation disorders. Various internal and external factors, such as sun exposure and medications, can however cause irregular pigmentation, referred to as dyschromia. There is usually no cure for most pigmentation concerns. For localized situations, you can teach your clients how to cover up or diminish the appearance of hyper and hypopigmentation with camouflage makeup. Refer clients to a dermatologist if they do not have one. You can also educate your clients about broad-spectrum sunscreen products to help prevent the progression of certain disorders, as well as the benefits of light exfoliation services. Hyperpigmentation appears in several forms. Losma. Closma is a condition characterized by hyperpigmentation in spots that are not elevated and is generally caused by cumulative sun exposure or aging. It is similar to melasma. Lentigines. Lentigines is the technical term for freckles, small yellow to brown spots on skin exposed to sunlight and air. Figure 414AB. They are also commonly referred to as liver spots in older adults, although there is no relationship to the liver. B. Figure 414A and B. Lentigines. Melasma. Melasma, also known as the mask of pregnancy, is a type of hormonal hyperpigmentation disorder that appears during pregnancy or with the use of birth control pills. It has an identifiable pattern of solid, fairly symmetrical hyperpigmentation, often on the forehead, cheeks, upper lip, and chin. Figure 415. Sun exposure can exacerbate the pigmentation of melasma, so a person may have melasma and sun damage. Spots can be helped by exfoliation or can be treated by a dermatologist. Figure 4. Nevus. A nevus, also known as a birthmark, is a malformation of the skin due to irregular pigmentation or dilated capillaries. Figure 416. Stain. Figure 416. Nevus. Figure 417. Port wine stain. A stain is an irregular brown or wine-colored skin discoloration with a circular or irregular shape. Figure 417. The permanent color is due to the presence of darker pigment. Stains can be present at birth, or they can appear during aging, after certain diseases, or after the disappearance of moles, freckles, and age spots. Tan. A tan is a change in skin pigmentation caused by sun or ultraviolet light exposure. Hypopigmentation. Hypopigmentation disorders are seen less commonly than hyperpigmentation disorders. There are various forms of albinism. Figure 418 Albinism. Albinism is a rare genetic condition characterized by the absence of melanin pigment in the body, including in the skin, hair, and eyes. Hair is often white, while the skin is pinkish white, will not tan, ages prematurely, and is sensitive to light. Figure 418. The technical term is congenital hypopigmentation. Leukoderma. Leukoderma is a skin disorder characterized by light or white irregular patches. Hypopigmentation, caused by a burn, a scar, inflammation, or a congenital disease that destroys the pigment-producing cells. Examples are vitiligo and albinism. Vitiligo. Vitiligo is a hereditary condition that causes hypopigmented spots and splotches on the skin that often appear milky white. Recent research suggests that this disorder is part of an autoimmune disease. Figure 419. Skin with vitiligo must be protected from overexposure to the sun. Figure 419 Vitiligo. Check-in 9. Name and describe at least 5 skin pigmentation changes. 88 part. Low 7. Identify and describe major acne causes and current treatments. Acne and problem skin. Common skin problems that affect clients' appearance, such as acne, can be emotionally devastating. Acne is a skin disease that is thought to be a teenage skin disorder, but can affect people of all ages. Cosmetologists and estheticians can help clients with treatment for minor cases, and provide dermatological referrals for more severe acne. Heredity and hormones. A predisposition to acne is due to heredity and hormones. People with acne inherit the tendency to retain cells that gather on the follicle walls, eventually clumping and obstructing the follicle. Hormone levels directly affect the function of the sebaceous glands, increasing or decreasing the amount of sebum on the skin. Retention hyperkeratosis. Retention hyperkeratosis is the hereditary tendency for acne-prone skin to retain dead cells in the follicle, forming an obstruction that clogs follicles and exacerbates inflammatory acne lesions, such as papules and pustules. Skin's oiliness is also hereditary. Overproduction of sebum by the sebaceous glands contributes to acne development by coating the dead cell buildup in the follicle with sebum, which hardens due to oxidation. This conglomeration of dead cells and solidified sebum obstructs the follicle. Acne bacteria. Propionibacterium acne, P. acnes, is anaerobic, which means that these bacteria cannot survive in the presence of oxygen. When the follicles are obstructed, oxygen is blocked from the bottom of the follicles, allowing acne bacteria to multiply. Acne bacteria's main food source are fatty acids, which are easily obtained from the abundance of sebum in the follicle. These bacteria flourish in this ideal environment, which has plenty of food, sebum, for the bacteria and is void of oxygen. The bacteria multiply, causing inflammation and swelling in the follicle, and eventually rupture the follicle wall. Then the immune system is alerted, causing blood to rush to the ruptured follicle, carrying white blood cells to fight the bacteria. Blood surrounds and engulfs the follicle, which is what causes the redness in pimples. An acne papule is an inflammatory acne lesion resulting from this wall rupture and infusion of blood. A pustule forms from the papule when enough white blood cells accumulate to form pus, which is primarily composed of dead white blood cells. Cosmetologists and estheticians cannot treat acne papules. Grades of acne. Acne is graded on a scale of 1 to 4. Table 4.3. Grade 1 acne is mild and usually treated with over-the-counter skincare products, whereas Grade 4 acne has progressed to consistent breakouts and deep cysts that require medical intervention. Activity. Skincare product search. Go into a pharmacy, or research online, to find 3 skincare products per acne grade. 1-4. How is each used? Chapters. Table 4.3 Grades of acne grades of a CNE. Grade 1. Minor breakouts, mostly open comedones, some closed comedones, and a few papules. Grade 2. Many closed comedones, more open comedones, and occasional papules and pustules. Grade 3. Red and inflamed, many comedones, papules, and pustules. Grade 4. Cystic acne, cysts with comedones, papules, pustules, and inflammation. Scar formation from tissue damage is common. Acne treatment. Mild forms of acne can be treated without a medical referral. The basics of mild acne treatment involve daily use of gentle cleansers formulated for a specific skin type. Foamy rinse-off products remove dirt, debris, and excess oil from the skin. Harsh cleansers can make the skin too dry, causing sebaceous glands to generate more sebum, creating an even bigger problem. Toners may be helpful for clients with excessively oily skin. Use of leave-on follicle exfoliants that help remove cell buildup from the follicles and allow oxygen to penetrate the follicles, killing the bacteria. Commonly used ingredients in these products are alpha-hydroxy acid, salicylic acid, and benzoyl peroxide. Benzoyl peroxide can be especially effective, since it helps shed cellular debris and kill the acne bacteria. Use of mild exfoliation treatments that gently slough dead skin cells, such as those formulated with salicylic acid. Avoidance of skincare and cosmetic products containing large amounts of fatty materials and oils, which can clog follicles. Use makeup and skincare products that are non-comedogenic, which means the product is designed and proven not to clog follicles. Use of a light moisturizer to keep skin balanced and reduce the risk of excess sebum production. Check in 10. What are the two major causes of acne, and how should they be addressed? 90-part. Low 8 list contributing factors to skin aging. Aging skin issues. Skin aging is a common concern for clients. Two types of factors influence skin aging: intrinsic and extrinsic factors. Though aging is a natural process, these factors play an important role in how the skin ages and can influence our overall health. Intrinsic factors. Intrinsic factors are skin aging factors we have little control over. They are due to the years passing, wearing out of the body, and hereditary factors, genetics and ethnicity. Genetics includes the genetically determined aging process that occurs naturally and is affected by the degenerative effects of free radicals, hormonal shifts, and the body's inability to perfectly repair skin damage. Intrinsically aged skin shows epidermal and dermal atrophy, a reduced number of fibroblasts, and less collagen production. Ethnicity also influences skin aging, primarily because of the differences in skin pigmentation. High levels of pigmentation help protect the skin from the cumulative effects of photoaging. Gravity. Gravitational pull is a constant pulling downward on our skin and bodies and is a consistent skin aging factor for everyone. When the skin becomes less elastic, gravity makes eyebrows and eyelids droop, creates looseness and fullness under the cheeks and jaw, jowls and double chin, and even lengthens earlobes. Repetitive facial expressions. Facial expressions are movements of the face that result in expression lines, such as crow's feet around the eyes, nasolabial folds that form from the corners of the nose to the corners of the mouth, and scowl lines between the eyes. Extrinsic factors. Extrinsic factors are primarily environmental factors that contribute to skin aging. Of radiation. Tanning and sunbathing are significant contributors to both aging and skin cancer and should always be discouraged by skincare professionals. However, the cumulative UV rays from sun exposure that we absorb in small doses every day also significantly damages the skin of most people. Figure 420. The key to prevention is using a broad-spectrum sunscreen or a daily use moisturizer with built-in sunscreen every day. Help your clients find the best ones for their needs. Smoking. Smoking significantly damages the skin as well as the lungs. It produces tremendous numbers of free radicals, unstable molecules that cause biochemical aging. These molecules, over time, can have a devastating effect on the body, causing skin water loss. Sunlight-free radicals. Impaired cell renewal. Toxin accumulation. Poor nutrition. Heavy light. Pollution and irritants. Reduction in collagen, elastin, and hyaluronic acid. Figure 420. Premature aging. Wrinkling and sagging, particularly on the face and neck. Smoking also deprives the skin and body of oxygen, ultimately affecting blood flow, preventing the skin from receiving adequate nutrients. This lack of blood flow causes the accumulation of cellular waste. Alcohol. Overuse of alcoholic beverages negatively affects the body, including the skin. Alcohol inhibits the body from repairing itself and interferes with proper nutrition distribution to the skin and body tissues. Alcohol also dehydrates the skin by drawing essential water out of the tissues, causing the skin to appear dull, dry, and more aged. Stress plays a significant role in our overall health and contributes to premature aging of all organs, including the skin. Research confirms that stress causes biochemical changes at the cellular level leading to the tissue damage we call aging. Exercise, relaxation techniques, and a healthy mindset can reduce stress levels, as can relaxing treatments like facials, aromatherapy, and massage. Poor nutrition. Poor eating habits deprive the skin of nutrients required to maintain, protect, and repair the skin, keeping it from looking young and beautiful. Eating a well-balanced diet allows the body to nourish the skin's fragile tissues. One of the first signs of eating disorders is the dull complexion associated with repeated deprivation of needed nutrients. Pollution. Pollution exposure produces free radicals, interferes with proper oxygen consumption, and affects the lungs and other internal organs as well as the skin. Routine washing and mild. 92. Exfoliation. Removing dead surface skin cells. Help remove the buildup of pollutants that settle on the skin's surface throughout the day. Daily moisturizers, protective lotions, and even foundation products help protect the skin from airborne pollutants. Here's a tip check-in. 11. Give 3 examples of intrinsic factors. 12. Define the term extrinsic factors. The appearance of aging skin can be greatly improved by a professionally designed program based on the client's skin type and specific needs. It should include a good hydrating sunscreen, an alpha or beta hydroxy acid exfoliating product, and products with state-of-the-art ingredients such as peptides and topical antioxidants designed specifically for aging skin. Low 9. Explain the effects of sun exposure on the skin. Sun damage. The sun's ultraviolet UV light has the biggest impact on skin aging of all extrinsic factors. Approximately 80 to 85% of aging skin symptoms are caused by the accumulated effects of damaging rays from the sun. 2. As we age, the skin's collagen and elastin fibers naturally weaken, and this weakening happens at a much faster rate when the skin is frequently exposed to UV light without proper protection. When we call UV light a UV ray, it is just a shorter way of saying that it is a form of radiation, which can be damaging. Consider that a sunburn can actually lead to second-degree burns. Figure 421. Sun protection. The most common form of sun protection is sunscreen, applied to the face and body in anticipation of time in the sun. SPF stands for sun protection factor, and this number roughly designates the amount of time a person can be in the sun without burning. However, sunscreen works only when applied correctly, and the actual amount of time that any specific SPF can offer protection is based on the time of day, altitude, skin type, and amount of product applied. Clothing offers some barrier SPF, but it is minimal, so applying sunscreen along with protective clothing is ideal. The Skincare Foundation describes fabric effectiveness by its UPF, or ultraviolet protection factor, signifying how much UV radiation reaches your skin. Most cotton shirts offer about UPF 7 and even less protection when wet. Caution. Advise your clients to avoid exposing children younger than 6 months to the sun. Physically shield them from the sun, rather than use sunscreen. Advise clients who are prone to burning easily to wear a hat and protective clothing when outdoors. Be dedicated to properly choosing and applying sunscreen. Redheads and blue-eyed blondes are particularly susceptible to sun damage. Activity sunscreen. Look at the SPF information on a bottle of sunscreen. Is it broad spectrum? Does it contain zinc oxide or titanium dioxide? How often should it be applied? 2 types of rays, UVA called aging rays, and UVB, called burning rays, are responsible for skin tanning and burning. Use a sunscreen labeled broad spectrum, indicating it protects against both UVA and UVB rays. Although some older sunscreen labels may contain the words waterproof or sweatproof, those claims are no longer allowed by the U.S. Food and Drug Administration (FDA). A sunscreen may be labeled only as water-resistant and must indicate whether it is water-resistant for 40 or 80 minutes. Advise clients on protecting their skin from the sun's damaging rays and the risks of skin cancer. Stay up to date on the latest information and rules surrounding sun protection by reading current articles and visiting websites like www.fda.gov. Avoid prolonged sun exposure. Avoid prolonged exposure to the sun during peak hours, when UV exposure is highest. This is usually between 10 a.m. and 4 p.m., which can be extended when at high altitudes or areas closer to the equator. 3. Properly apply sunscreen. Apply sunscreen at least 30 minutes before sun exposure to allow time for absorption. If you apply sunscreen after being exposed to the heat and sun for 30 minutes or more, the already inflamed skin is more likely to react negatively to the sunscreen's chemicals. Reapply sunscreen. Apply sunscreen liberally after swimming and after activities that result in heavy perspiration. If the skin is exposed to hours of sun, such as during a boat trip or day at the beach, apply sunscreen periodically throughout the day as a precaution. Check-in 13. Explain the effects of sun overexposure on the skin. 94. Low 10. Identify the forms of skin cancer, including symptoms and survival rates. Skin cancer. Nearly 3.5 million people are diagnosed with skin cancer every year, making it one of the most common cancers. 4. It is also becoming one of the most common causes of cancer-related deaths because of general complacency about prevention and a lack of knowledge about the signs and real risks, particularly in young people. Cosmetologists should recognize the signs of potential skin cancer and always refer clients to a physician if necessary. It's better to be safe than sorry. Do not let someone's young age or general good health stop you from encouraging them to receive early diagnosis and treatment. There are 3 types of skin cancer. Table 4.4. Table 4.4. Benign, harmless and malignant cancerous skin lesions. Image: benign mole. Description: small spot on the skin ranging in color from pale tan to brown or bluish black. Note: this is not a type of skin cancer. Basal cell carcinoma. Most common and least severe skin cancer, characterized by light or pearly nodules, has an 85% to 95% recurrence-free rate with early diagnosis and treatment. 5. Squamous cell carcinoma. More serious than basal cell carcinoma, characterized by scaly red or pink papules or nodules, also appear as open sores or crusty areas, can spread to other parts of the body. Survival rates depend on the stage at diagnosis. Malignant melanoma. Least common, but most dangerous form of skin cancer, characterized by black or dark brown patches on the skin that may appear uneven in texture, jagged, or raised. 100% fatal if left untreated. Early detection and treatment may result in a 99% 5-year survival rate for the localized stage, but that drops drastically, 66%, once it reaches local lymph node 6. Here's a tip. For more information, contact the American Cancer Society at www.cancer.org or 800 AX 2345. Recognize skin changes. Skin cancer is preventable, and early detection is possible if you know what to look for. Be aware of the following as you service your clients: unusual lesions on the skin or the scalp, or changes in color, size, or shape of an existing lesion or mole. Common melanomas, irregularly shaped dark spots on the scalp and ears, often first detected by cosmetologists. A new lesion or discoloration on the skin or scalp. Client complaints about sores that do not heal or unexpected skin bleeding. Recurrent scaly areas that may be rough to the touch, especially in sun-exposed areas such as the face, arms, or hands. If you discover any of these conditions, suggest that your client consult a dermatologist for diagnosis and treatment. Advise clients to regularly see a dermatologist for skin checkups. If detected early, anyone with basal cell carcinoma, squamous cell carcinoma, or malignant melanoma has a good chance of survival. An example of a problematic skin condition is actinic keratosis. This is a precancerous lesion that feels sharp or rough and is caused by sun damage. Benign mole. Symmetrical melanoma, asymmetrical. Home self-examinations can also be an effective way to check for signs of potential skin cancer between scheduled doctor visits. When performing a self-care exam, clients should check for changes in existing moles and pay attention to any new visible growths on the skin. Also advise clients to ask a friend or loved one to check areas they cannot adequately see on a routine basis, including the back, the scalp, and around the ears. Act of melanoma detection. Benign mole, 1 shade melanoma, 2 or more shades. According to the American Cancer Society, professionals should use the ABCDE cancer checklist to spot signs of change in existing moles. Figure 422. Look for changes in any of the following. A. Asymmetry. One half of the mole does not match the other half. B. Border irregularity. The mole's edges are ragged or notched. Benign mole, even edges. Figure 422. 96 melanoma, uneven edges. Benign moles compared to cancerous moles that show signs of asymmetry and changes to border, color, and diameter. Part 02. HLTHS Sheen says. Copyright D. Diameter. The mole is wider than about 0.25 inch, 0.5 cm, although doctors are now finding smaller melanomas. E. Evolution. The mole evolves or changes. This process may include darkening or variations in color and changes in shape or growth. The mole may also itch or hurt. Check-in 14. Name and describe the 3 forms of skin cancer. Low 11. Describe contact dermatitis and prevention measures for cosmetologists. Contact dermatitis. Dermatitis is a generalized term to refer to an inflammatory condition of the skin. Contact dermatitis is a skin inflammation caused by contact with certain chemicals or substances. It is the most common work-related skin disorder for cosmetology professionals, as many of these substances are used in cosmetology. There are 2 types of contact dermatitis: allergic contact dermatitis and irritant contact dermatitis. Allergic contact dermatitis. Allergic contact dermatitis (ACD) occurs when a person develops an allergy to an ingredient or a chemical, usually caused by repeated skin contact with the chemical. Sensitization is an allergic reaction created by repeated exposure to a chemical or a substance. Monomer liquids, hair color, and chemical texture solutions are all common causes of allergic reactions with repeated exposure. Once a product allergy is established, the person affected by the allergy, cosmetologist or client, must stop using that particular product until the allergic symptoms clear. In severe or chronic cases, affected people should see a dermatologist for allergy testing. Common places for allergic contact dermatitis include the fingers, palms, or back of the hands, face, especially the cheeks, scalp, hairline, forehead, or neckline. If you examine the area where the problem occurs, you can usually determine the cause. For example, when stylists don't consistently wear gloves for chemical or coloring services, they may find contact dermatitis on their fingers and hands. Irritant contact dermatitis. Irritant contact dermatitis (ICD) occurs when irritating substances temporarily damage the epidermis. Figure 423. Unlike allergic contact dermatitis, irritant contact dermatitis is not usually chronic if precautions are taken. Figure 4. Corrosive substances or exfoliating agents are examples of products with irritant potential. Contact with irritant chemicals can damage the epidermis because the irritant can enter the skin surface and cause inflammation, redness, swelling, itching, and burning. Repeated exposure can worsen the condition. Preventing contact dermatitis. Using gloves or implements when working with irritating chemicals is the best way to prevent both occupational types of contact dermatitis. Cosmetologists should use them when applying chemicals such as hair color, straighteners, and permanent wave solutions. Nail technicians should use them when applying nail products such as monomer liquids and polymer powders. Estheticians should use them when applying exfoliation products and drying agents. Frequent hand washing can dry out hands and crack the skin, allowing penetration of irritating chemicals and causing further irritation. Hand washing is important to prevent disease spread. but follow it with protective hand creams to keep the hands in good condition. Keeping your tools, equipment, and surfaces clean and disinfected is an important step in protecting yourself and avoiding skin problems. Practice these steps with great diligence. Keep brush handles, containers, and tablet tops clean and free from product, dust, and residue. Repeatedly handling these items will cause overexposure and skin reactions that, in some cases, could end your beauty career. Wear protective gloves whenever using products known to cause irritant or allergic contact dermatitis. Keep your hands clean and moisturized to prevent irritant reactions. Check-in 15. What is contact dermatitis, and how can it be prevented?